Hello, everyone. My name is Kangxin He. I work from the first affiliated hospital, Zhejiang University School of Medicine. Today, I'm gonna to introduce the patient-derived tumor organoid companion diagnostic PDTO testing for personalized oncology. In the first slide, I would like to introduce the concept of PTTO and companion diagnostic briefly. Patient-derived cancer organoids, PTTO, are 3D culture grown from tumor tissue specimen from biopsy or surgical resection. The PDTO recapitulates the functional structure and biological complexity of the tumor lesion, since they are one of the most promising models to study drug response and heterogeneity within and between patients. Based on its theoretically fidelity in drug response, people would naturally use PDTO in companion diagnostic in personalized medicine. Here comes to the other concept of companion diagnostic, CDX. The US FDA described the CDX is a medical device, often an in vitro diagnostic IVD, which provide information that is essential for the safe and effective use of a corresponding drug. Especially in cancer disease, we use CDX to guide any tumor therapy. For example, Roche developed a HER2 biomarker CDX to evaluate the HER2 expression in tumor lesion for its anti-tumor drug. However, having developed for decades, the anti-tumor drug usage still lacks the corresponding CDX. At present, only target therapy has its CDX. In contrast, most chemotherapy, the combined therapy and the personalized dosage adjustment lack CDX. I would say till today, the uncertainty definitely led to treatment failure. What should we do to solve the difficult problem? I believe functional precision oncology, such as PDTO, organ chip, PDX, will help. And for the future, the new PDX will predict efficacy, safety, dosage, and possible resistance for drug therapy. So people will ask, what is PDTO testing for anti-tumor therapy? The workflow of PDTO testing is as like as conventional tumor CDX. The only difference is the biopsy requires a fresh and viable specimen for organoid culture. Once we received the specimen, the tissue will be disassociated to cell suspension and cultured, and the established organoids colony will be treated anti-tumor therapies, and the viability of organoids will be tested to predict the drug response. There are many cohort studies reported PDTO testing was a very promising CDX for anti-tumor therapy. Here, I would like to introduce a systemic review published on Nature Precision Oncology in 2021. This review meta-analysis the 17 random trials of PDTO testing, and it concludes that the sensitivity of PDTO testing is 81%, and the specificity is 74. All trials are carried out to blind, and that is to say the PDTO testing. That is to say the PDTO testing and the routine anti-tumor therapy are carried out parallelly, and the consistency of the PDTO response and the clinical outcomes are examined during the follow-up of the therapy. The enrolled trials reported five different assessment methods for evaluating the drug response. There are growth rate, inhibition, area, and the drug response curve, their viability decrease, organoid size, optical metabolic imaging. The right image tells us that among the 17 trials, only two reported the PDTO response are not correlated to the clinical outcome. Since we got here, I would introduce the PDTO testing platform and the workflow that I have established. Firstly, when a lab receives a tumor sample, the specimen will be evaluated the sample quality, such as sampling method, transportation duration, and the cell viability of the cell suspension after the tissue cutting. That described by AOPI fluorescence image analysis. If the specimen is unsatisfied, the testing will be aborted. Secondly, the qualified viable tissue was disassociated to cell clusters, and the cell clusters were cultured as PDTO. The successfully grown organoids were examined its yield, viability, and pathological characteristics. Then third, the organoids were seeded in a 96 well plate for subsequent drug screen in concentration. In the drug screen, the organoid were exposed to plasma concentration of drug or drug combination for 3 to 5 days, and the organoid shape and size were monitored daily. And at the final of treatment, organoids viability were assessed via ATP content. We have developed a robust and sensitive ATP cell viability assay. It is relatively robust because response is stable with different generation. For example, here presents the CRC organoids very consistent across the third and fourth generation to a variety drug exposure, such like 5-FU, gemcitabine, and retrovirals. The ATP assay also displays excellent performance because the sensitivity extends the linear range of the assay to 4 logs, and the well-to-well variation was controlled with 0.6%, and the plate-to-plate variation were within 1%. We also established a drug exposure concentration formula that carefully considered data from the published literature of population pharmacokinetics. From this slide, I would like to introduce the good practice during we carry out PDTO testing using microscope, such as Constar's Castor S. The visual estimation of the PDTO growth will be always the most important when we use PDO as models. Typically, the typical morphology of cell or organoid with good vitality, for example, rapid healing of cell cluster, or clear boundary and high transparency, or significant or sustained volume increase, indicating the organoid is good, in good state. The bad state of organoids is typically has a disintegrated or partly disintegrated organoid boundary, or scattered cells or debris around the organoids, or shrinking or collapsing inward, and showing the overall black color. Here's some examples. And the contamination would be second important key that need to be monitored as early as possible, because you may estimate the contaminant organoid or purge the contaminant wells to rescue the rest organoid, or you may want to optimize the operating scales of the tissue version primary culture, or you might want to improve the cleanness of the environment. For the first, we want to discriminate PDO from contamination or lipid droplets. I think the microorganism colony grows first. Firstly, I think microorganism colony grows much faster than PDO, and the proteasome moves in matrigel. Other than other organoids are static, and lipid droplets are scattered and static. Second important is we want to discriminate the contamination is endogenous or exogenous. First, the endogenous contamination, the matrigel will discolor and getting hazy first. No spreading among adjacent well. The well is in regular location within the plate. And the exogenous contamination will present as the medial discolors and get it hazy first and spread among adjacent well. A wells in outer edge contaminate first. Here is some example. Drug exposure timing is also crucial for successful PDTO testing because treated too early may take a risk of shortage of sufficient biomass of organoids, and too late may take another risk of organoids of the organoids it's getting too older or to respond to the drug exposure. And I think when to passage and the organoids is also important. Organoid it's getting too big or too high cultivation density or continuous blackening of organoids and of accumulation of shedding dead cells in the internal chamber of organoids and subsequent process you needed to passage. And the drug treatment timing means I will choose when the PDTO has average diameter for 30 micrometer. It means the PDTO is grows vigorous, and you will and two questions you may ask yourself. At what stage will the PDTO express the target or present a certain phenotype, and how long will it last? Beside tumor organoids, organoids derived from non-tumor disease may also be interesting. One of the most concerned is the maturity of the differentiation and development, which is crucial for the organoids exact key mechanism of the disease of interest. This slide I would introduce how to estimate the PDO differentiation visually. The undifferentiated organoids usually present as uniform in size, thin walled and regular sizes, and it's present no or less blackening, and it always have obvious growth, and particularly for gut organoids, they have more budding. And the differentiated organoids always present as reduced transparency and irregular shape. And the organoid always will getting thick or more blackening and stop growing and less budding, especially for a gut organoid. And once we prepare the organoids appropriately, we subsequently carry out the drug exposure and organoids monitoring. I usually use the Starcaster as to monitor the organoids in its bright field channel and analysis PDO using the AI, the carried AI. Though the BF channel discriminates organoids not as sensitive and specific as fluorescent channel, the image capture and the AI analysis is non-harmful. So this function allows us tracking the organoids in a time course. In this slide, the left figure show example of AI tracking of intestinal organoids by timing lapse imaging, and the right figure presents an example of AI for discriminating drug response based on the bright field imaging. The AI marked the organoid survival by pseudo color after exposed to cisplatin for 3 days. Cisplatin, the organoids not only survive, indicated by green pseudo color, but even grow significantly. This suggested the organoid is resistant to cisplatin. On the contrary, another drug, gemcitabine treatment leads to dramatically death, indicating by the red pseudo color and collapse sharp to the organoid. Because the BF bright field imaging is not as good as fluorescent imaging in terms of signal chaos ratio, before PDTO testing reaches the final step of destructive ATPSA, we usually character the organoids using fluorescent imaging, also known as AOPI imaging here. using cornstarch caster. The AO means green color dye acting orange, and that bind to the DNA and that indicating living cells. And the PI means the red dye. It's protein iodine that only bind to the dead cell. Here, this slide show gastric cancer PDTO treatment with a cytotoxic drug mitomycin C. On the day 3 of the treatment, AOPI fluorescence image were captured, and the AI generated a variety of size-related parameters for us to evaluate the organoid response to the treatment. The AI successfully discriminates the mitomycin C and negative control by contrasted dyeing of the AO and PI. Here is this slide shows another example of AOPI imaging analysis by Custis S and its carried AI. PDTO were exposed to gradient 5FU from 0.0032 to 10 micromolar for 3 days. The AOPI contrast dyeing successfully described the dose-effect relationship of this gradient and generated IC15. IC50 was similar to ATP-assay. Here is another example for our PDTO testing platform. We combine the ATP-assay and the AOPI image analysis. This combination results in data more robust. Here is I would like to show the case study for our PDTO testing. And the tumor specimen was collected from the lung metastasis of CRC. One punctured needle have collected approximately 10 microgram tissue. The cell count is 10,000. And for the primary culture of and for a 6-day primary culture, we have generated a sufficient quantity of organoids. And the IC50 showed the drug response of this patient. We could find that the 4-FOXP3 and the oxaliplatin irinotecan combination is the better therapy. I think the trend of the PDTO testing for tumor companion diagnostic is the testing should be more automated and more characteristic-based standardized. The second is tracking PDO by using time-lapse imaging instead of endpoint testing. And third is multiple dimensional evaluation. For example, high throughput and high content imaging to replace the single indicator static evaluation. For example, ATP viability assay. The third is reduce the quantity required of tissue samples. This always applicable to puncture or endoscopy specimen. And the fifth is improve the success rate of PDTO cultivation. And the sixth is targeting vascular endothelium and targeting immune cells.